Good afternoon. Thank you very much for joining the webinar. I'm Dominguez Valentin. I'm the coordinator of PREDI-LYNCH, the EU project. And thank you very much again for your participation in this webinar, which is about patient experience with Lynch syndrome. And it's my pleasure to introduce the speaker for today's webinar, that is Kelly Kohut. Kelly Kohut is a lead consultant genetic counselor at the Southwest Thames Centre for Genomics, based at St. George Hospital in London. She is also a Macmillan professional and an NIRR Mid-Career Research Fellow at the University of Exeter Biomedical Research Centre. Kelly Kohut holds a PhD in health science from the University of Southampton and has over 20 years' experience in genetic counseling across Canada, United States, and UK. Her research focuses on personalized cancer risk communication, shared decision-making, and patient co-design of behavioral intervention. She is also General Secretary of the European Hereditary Tumor Group, serves on the Expert Advisor Board for PREDI-LYNCH, and advises on research grants, charities, and student projects. It's my pleasure to have you, Kelly Kohut, here in the PREDI-LYNCH webinar. And if you all have no objection, we would like to record the presentation for dissemination within our partners or in the social media. Okay. Then it's my pleasure to give the floor to Kelly. Thank you very much.
Thank you so much, Mev, and thank you everyone for allowing the recording. I know there were some people who would like to join, but don't happen to be available at this particular time. So thank you everyone for being here. I'm not the expert on patient experiences firsthand. That's I think some of you are probably some patient representatives who have joined the call, which I'm quite excited about. And we'll have, I expect, a mixed audience of clinical, maybe some academic colleagues, as well as the PPI, which is wonderful to see. So thank you for the introduction, Mev, and for inviting me. I can go into the aims for the presentation today on the next slide. So there's a lot that could be covered, and I think that maybe there'd be opportunity to connect with some of you in future if you want to put questions in or feedback or contact me afterwards. And I hope that there's going to be many collaborative projects as we work together towards some of these shared aims. But for the purposes of the webinar today, I want to talk about the importance of the personalized nature of communication about inherited cancer risks such as Lynch syndrome and the complex management choices that come along with that. Give some examples of patient and public involvement, or PPI, in research, and also design, co-design together of patient resources. And I'll use Lynch Choices as an example, and it's just one of many excellent resources that have been co-designed and are starting to be out there for people to find and use. I'll talk about some of the challenges and benefits of collecting directly from patients. So you telling us firsthand what your outcomes are, what your experiences are, but how these are important and could inform the priorities and drive forward the clinical service development and the research. And I hope to share some tips and maybe encourage others to get involved, either as a researcher or clinician or as a PPI representative in some of the projects. There's so much to do together, so everyone has a place in that, and I hope that you can feel confident to think about taking it on. And as an overarching theme, just showing how PREDI-LYNCH is addressing so many of these challenges in practice, and will be able to inform international approaches in the near future. So moving on to the next slide. Thanks, Mev, for doing that. Thinking about, why is personalized risk communication about these cancer risks and the management choices so important? Each person is an individual. They will have their own priorities, and there's not really any one size fits all that can fit the communication and the shared decision making and the genetic counseling around that. Broadly, the definition, it's a slightly older one, but quite well accepted, of genetic counseling is that it's a process of helping people to understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. And the next slide, I'm thinking about who provides genetic counseling. So there's genetic counselors like me, but using genetic counseling as a verb, something that can be done by others and is. We have doctors who are geneticists, or especially we're thinking about cancer genetics, oncologists, surgeons, people who are working in oncology practice, cancer services, could be gynecologists, gastroenterologists working in secondary care, general practitioners or family doctors, nurses, allied health professionals, psychologists. And then on the other end, getting the actual samples from the patients, scientists, pathologists, how they interpret the tests is very important. So it's very much a multidisciplinary field, lots of us working together. And we had this report in the UK, the Topple report, recommending that all clinicians should have genomic literacy, should know how to answer questions from patients about genetic testing and how to order testing. So this requires a huge expansion in the capacity to deliver genetic counseling. It's really involving lifelong learning. This is a field that does not stand still. There's always new advances to keep up with, and there's a challenge to actually empower patients and the public to have transparency about what's going on, what's being planned, and to have their trust in that process. So moving on to the next and the next, thinking about how the service is needed to change to scale up to deliver genomic testing on such a hugely increased scale, to try and embed it across virtually all areas of medicine, and certainly in cancer, it's become incredibly important. So the traditional model was very intensive, but it could be quite slow, and it's not, it's not fit for purpose now. Certainly having everyone referred to specialist genetic services, have pre-test genetic counseling, a detailed family history, and then very limited access to genetic tests, and then having to come in person for every result, whether we found something or not, and having regular follow-up appointments with everyone. It was a nice model, and it was the original way that things were done, but it's just simply not possible with the scale of testing now. So the newer model, certainly in the UK where I work, I know it's different across Europe and other countries, how things are evolving, but we have a much more mainstreamed model of genetic testing, where testing is often ordered and results are given by non-genetic specialists. So it could be in oncology or other services. We're moving towards more, or maybe even all people diagnosed with cancer would have some type of genomic screening or genetic screening, maybe of their tumor, and then also of the germline, which is usually a blood test to look at the DNA, also that they've inherited, not only genetic changes that have happened in the tumor itself. And then getting referrals after the test results are available to specialist genetic services like mine. Maybe we're only seeing the people where something's been found. There's a likely pathogenic or disease-causing variant, or what we used to call a mutation in a gene. Maybe there's a complex variant interpretation that needs our expertise. And also we see the people who are in the family, so cascade predictive testing once a familial variant has been found, to offer that to relatives who maybe have not had cancer themselves. So there's a lot of different scenarios, also special communication needs or psychosocial factors, which may mean that people need a little bit of extra support, maybe more of the traditional model. But for most of the testing now, it's often mainstreamed at the point of diagnosis. We also use a lot of registers and databases to keep track of people so that they can be recalled when they need a screening appointment, or maybe to get information from genetics or about research studies that they might be eligible for. And moving also to a model of where it's patient-initiated follow-up, or PIFU. So it's saying to people, there is an open door, but we ask you to please come back when there's something that you would like to have our input. You know, it may be things that crop up at different times across their lifetime when they would find genetic counseling helpful. So rather than having an appointment every year, it's more led by the timeliness of having something that they want some help with. So there's lots of strategies. Not all of them have been delivered in the same way or in different regions and countries, but I think there's you know, PREDI-LYNCH is really bringing together this kind of strategy to integrate, have an overall arching program that can help people to benefit from some of the advances, things like clinical decision support systems, or ways that we can integrate into routine pathways, electronic medical records, streamlining the information giving, consent process, using digital platforms, maybe sending kits to people's home rather than having them come to hospital for testing. More non-invasive ways of testing that are part of the study. And then a lot of education as well, just to keep healthcare professionals up to date with what is available and how they can help their patients access those things at the right time. In my area, a lot of work on patient-facing resources that are co-designed with patients who will use them, and decision support interventions to try and bridge some of the gaps that have been reported. So really leveraging the shared infrastructure and learning from each other, and then, you know, taking what works and trying to deliver it on a larger scale, and developing the workforce along with it so we can do that. And the next one, there's a lot of choices that come along with just Lynch syndrome, for example, and other inherited cancer predispositions, so that we have surveillance aimed at earlier detection of cancer where possible. So, for example, colonoscopy regularly from a young age, and more other ways of screening for cancers are being researched now, including non-invasive testing. So PREDI-LYNCH is a good example of thinking about how we bring that in. Primary prevention, it could be taking steps to avoid risk factors before cancer develops. So it could be, for example, in Lynch syndrome, changing diet, having more fiber, or other things like risk-reducing surgery to remove the uterus, and sometimes the ovaries and fallopian tubes, taking daily aspirin for at least 2 years to lower risks of cancer. And now we see vaccines coming in to try and activate the immune system to lower the chances of cancer developing, or attack early lesions that are starting to develop. So once someone has had a diagnosis, there may be targeted treatment like immunotherapy. And then there's the familial aspects, so talking to children, talking to relatives, sharing the information, helping people to connect with local genetic services so they can be tested, and family planning if anyone's planning a pregnancy or wants to think about IVF, and having pre-implantation genetic testing. So this is a picture from one of our EHTG meetings of Tracy Smith from Lynch Syndrome UK talking about some of her experiences, and Georgina Hoffman on the stage with me there did the same. So these are really complex decisions. They're not just one time. They're things that happen across the lifespan. They can be interrelated, and they can be influenced by a lot of things. So PREDI-LYNCH focuses on getting better evidence, personalized support, and really getting a real-world evaluation of what these things are like for people. And in the next one, we think about how is genetic counseling really an example of shared decision-making. It's a partnership between the patient and the person providing genetic counseling. It's asking the person as an individual, what is most important to you now at this point in your life? Who else might be important in making your decision? Are there loved ones who are going to influence it? What else is going on? They may have other health issues or other things in their social context that are priorities and are going to affect the decision at that time. So sometimes it's not making a certain choice right away, but knowing that it's there and then coming back to it with the right information at the right time. So this is, I'll be showing some examples of screenshots from Lynch Choices, which is it has a lot of information, links to other websites and support, and also 2 decision aids. So one is about taking daily aspirin and laying out the choices, saying, there's no right or wrong because everyone is different. The illustrations have been done by Lily Barnett, a genetic counselor in my service and a science illustrator. So I hope you can scan the QR code and have a look yourself. There's a lot more than what I can possibly show you in this webinar, but really encourage you to look and share any feedback with me. PREDI-LYNCH is also a great example of how we can operationalize shared decision making through making things like decision aids available, patient-informed design, and impact evaluation on real people's decisions as they move through these complex choices. And in the next one, the goals of genetic counseling are they're overarching sort of the clinical, so getting across the clinical advice, the guidelines that are there for people for what screening and so forth they might be able to access, but also thinking about the psychological aspects of those choices. And we know that, even if people believe something to be true or it's important to them, it doesn't mean that it necessarily translates into behavior. Even they might say they've made a decision, but it doesn't necessarily mean they'll go on and make that change or take that action or behavior. So this is quite a complex area, and genetic counseling can help to bring these things together by being a real personalized, tailored communication, translating really complex genetic information, hopefully into ways that people can understand, that's meaningful for them and engaging, and really are experts in family communication, because that's a big issue that comes up. They might not speak to certain relatives, or it might be difficult to bring things up, or maybe we can provide letters and ways of sharing information that makes it a bit easier for the families. So we are very experienced in dealing with that and trying to advocate for people and empower them to make the choices that are right for them. Coordination of care is a big issue. It's not always joined up and integrated, but that's an area we need to try and improve. For Lynch syndrome, just as one example, there's multiple different organs, different time points of when people might want to be accessing appointments and screening. So it's quite complex to navigate. It spans across primary care, secondary care, and tertiary care, which is specialist genetics. And we need to deliver age-appropriate information and care across really the whole lifespan. And there's ethical and legal issues that can come up for people as well. So PREDI-LYNCH is a great example of thinking about this and asking, how will we know how individuals with Lynch syndrome feel about having this screening, being part of research, and importantly, they're planning to evaluate patient-reported outcomes and the engagement measures systematically. So that will be a part of the project that hopefully will be included in future presentations for you to hear about. And in the next one, we have some screenshots from Lynch Choices, the QR codes there, the website, or you can simply Google it and it should come up for you. And one reason why it comes up very easily in a search is because we have so many partners who are also sharing it. For example, Lynch Syndrome UK, Lynch Syndrome Ireland, CAP3 study, the International Lynch Syndrome Database, which is connected via a live link to Lynch Choices, so that when you go into Lynch Choices, it doesn't just give you a static set of information. It actually is something that you can interact with. You can put in, if you know which gene has the variant for your family, you can select that so that it'll only show you the information about cancer risks for MLH1 or MSH2 or MSH6 or PMS2 or EPCAM. And so it's trying to make it more interactive and more personalized for people. So do have a look and let me know what you think. Always keen to hear from you. On the next page, I have this leaflet, that's page 1, and the next page is page 2 of a leaflet that was created by one of the genetic counselors in my service, Alekia Ashakan. So if anyone wants a copy of that, very, very happy to share. Maybe if there's an email list, we can send it out. This is just sort of two sides of one piece of paper that can be given out to people if they want something printed out that they can take home, and then it has a QR code that they can then later go on the website and maybe revisit it over time when they think, oh, I wasn't ready to think about aspirin then, but now I am, maybe dip back into it at the right time. So moving on to the next slide, the second page of the leaflet, and then moving on again, you can see a little bit more detail of the two decision aids that were co-designed. This is based on theory, psychological theories. It involved in-depth research and a literature review and a lot of patient and public involvement. And it was done over about a 5-year time project that was funded by Cancer Research UK as part of a larger Catalyst program grant called CanGENE CanVar. So these decision aids were developed from scratch, and I think they're quite unique. And one of them is about the choice to have the ovaries or the uterus removed. Not everyone has the ovaries removed. It depends which gene and what the risks are and other factors, but gynecological risk reducing surgery and the choice to take hormone replacement therapy if appropriate is covered in that. And then the other one is about taking daily aspirin. And my colleague, Professor Sir John Byrne, who did the CAP2 studies about daily aspirin and Lynch syndrome and completed the CAP3 study, soon to be published, about the dose that we recommend. So we're now saying we can safely recommend the lower dose of aspirin to be taken for at least 2 years. So there's an awful lot for people to think about there as well. And we've included lots of information as well as links out to CAP3 website and other websites to give information about that. So there's lots for you to look at there if you wanted to go on the website. If we go into the next page, I can just show you some brief shots of what it kind of looks like. So in a decision aid, we should lay out the choices. One is to not do anything now, but the language around that is quite important. People might not, some people told us during the project that they didn't like the term "don't do anything" or "I'm not doing anything." They're saying, well, I understand the information and that the choice is there for me, but I'm not ready to take aspirin or have surgery, for example, because they wanted to have more children or something else was needed to be dealt with first before they could get to that point. So it's saying wait to decide later. So laying out the choices side by side and what's called an options grid, so that people can really think, okay, these are my options and what might be important to me when I'm thinking about them. So on the next page, you can see an example of how we've included visual presentations of risks. So rather than just putting down numbers, percentages, we've included, these are called icon arrays, where you have the same number of people in each column, and then shading in the number of people who would be expected to be diagnosed with bowel, colon cancer, colorectal cancer, if they took aspirin versus if they did not take aspirin. So that's a guideline for best practice of how to communicate risk to people so they can actually have the denominator, which is the total number of people, and see how many out of that same denominator would be expected versus not. So it's kind of an easy way to visually understand the numbers a bit more. And this is also included in a decision aid in the UK called NICE about should I take aspirin. And on the next page, I think this is highlighting, this is not replacing shared decision-making with a healthcare professional. It's made to complement it as a patient-facing resource that can be accessed at home in your own time, or maybe in clinic together with a doctor or nurse or whoever you're seeing. But it's a partnership, and it's just adding extra information that's accessible and available to people to work through in their own time, and really to think about what questions you might want to bring in when you are seen. So here it's linking out to a CAP3 website, for example, and there's lots of places where we provide links to other resources. So on the next one, it shows some more lovely illustrations by Lily, which is about, what are the side effects? Because people often have questions about that, like they might bruise a little bit more easier, but for most people that doesn't cause them serious medical issues. It might be a little inconvenient, but the people who had more serious side effects were mostly older, and that's why in the UK at least we recommend stopping at age 70. 70 years old to avoid having a higher risk of side effects in that group. And then on the next one, we can see the idea that, okay, you might not be making that choice, but then linking out to other choices. So maybe you're not in a position to be taking aspirin every day or having risk-reducing surgery, but are there other things that people might consider doing? So certainly for bowel or colorectal cancer, and also for endometrial cancer, uterine, there's risk factors that are linked into diet and exercise. So there might be things that people can feel, okay, I'm taking an action that's going to be helpful maybe for reducing cancer risk, but it could also be helpful for lots of other reasons, making them feel more energetic. By having a healthy weight and being physically active can really help people, psychologically as well, if they feel, a good feeling from being out and being active and maybe being outdoors. So there's kind of interrelated things that can help people in a more holistic way as a whole person, and not only thinking about one choice about lowering cancer risk, but maybe thinking about other things that might be considered in their lifestyle. And those are not easy choices either. Trying to change your diet, having more fiber is not necessarily an easy thing, but it could be maybe taking a small step, seeing how that goes, and then maybe adding in other things later on. So there's a section on lifestyle and some information about diet from Bowel Cancer UK and the World Health Organization. And I think there's a lot more we could add with some of the dietitians that I've heard give presentations recently, have some nice ideas for people that are practical of changing diet. So the next page shows some symptoms. So people might think, I don't really know what the symptoms are, or how to separate them from things that people are experiencing all the time in the general population, but are not actually a sign of cancer. So just the key things to look out for bowel cancer. And then on the next page, there's a summary. When you work through on the website, there's a decision exercise where you weigh up kind of what's important to me at this time, and you can put check marks along the scale, and then it will calculate kind of, it seems like you're leaning towards doing this or not, or you're not decided and maybe you need to wait and ask some more questions. So it's designed to bring along, you could even print this out and note down your questions, because it can be hard to remember. When you go to a clinic appointment, it might be very rushed. There's a lot to discuss and you just don't find the time to ask the things that you wanted to ask. This can be a really helpful memory aid to bring it in and make sure you get those questions answered. And then you can go back to it later and change your answers as things change for you over time. And maybe your knowledge evolves of what you found out, or, things change for you in other ways in your life. So that can be revisited. And on the next page, we have a similar set of illustrations, but thinking about the symptoms of womb or endometrial or uterine cancer, which is quite important for people to know about and not ignore if this happens, and not feel like, you're bothering the doctor if you go and ask them about things. It's very important, especially if someone has Lynch syndrome, they have a higher risk than the average person, then it's important for them to be extra aware of the symptoms and make sure they feel comfortable going and reporting them if they're worried about anything. And on the next page, you can see we have different ways of giving information. So these are real videos of real people, individuals with Lynch syndrome, and also some ones that are fictional stories with illustration. So people like videos sometimes, and sometimes they don't. They just want to read information. So it's designed to have choices where people can delve into things as much as they want to, in the level of detail and also in the way that they want to, whether it's video or reading something. And on the next page, you can see we also went out into the community and filmed, not all of these people have Lynch syndrome, but they've all had cancer, and they've shared stories that, are quite powerful. And it was done in a relaxed setting in a barber shop. So that was a different way of, engaging people that maybe didn't take part in a formal research patient panel, but they were willing to just come on one day and come to a community event like this to share their stories. And then on the next page, there's an example of how we worked with colleagues in India and my colleague in London, Professor Manchanda, who did some infographics with us for getting across some of the diet and lifestyle advice for people who maybe weren't following a Western diet, because you find a lot of the resources are just assuming people have um, a Western diet, whereas I know even in the area where I work in Southwest London, there's a large proportion of Asian families who maybe follow a different diet. So we did these infographics. And then on the next page, you can see some wonderful work that was done by Mev and colleagues in Peru to create a website, Prionco, about hereditary cancer. So this is a really beautiful website, and there's some plans to try to apply, well, it's under review, get some more funding to create a resource in Norwegian. So I really hope that that's coming soon. And on the next page, I'll just get into a little bit of the example of the PPI that was included in this project. So as I said, as part of a bigger grant called CanGENE CanVar, and the panel were involved in lots of different activities, but particularly with my work package of co-designing patient resources, they were very heavily involved and engaged. And I think that was important. They were funded into the grant from the start. They were brought in and they had varied experiences, but they were led by a chair who was quite experienced, and they did seem to appreciate that they had one person who could kind of represent them, organize them, send communications, and so they knew who kind of a point person of who to contact. And a lot of them were key research partners right from the beginning. Some of them joined a little bit later on. We had up to 13. We never really had everyone come to everything because they're all very busy with their own lives, but we had enough representation for any of our in-person or online workshops and discussion groups to really hear from varied perspectives. And then adding on to that, some of the work I mentioned was going out in the community, working with specific charities to hear from more patient voices that weren't included on the panel. So yeah, this is another example of one thing we did that was in person, and we published a paper about it, of thinking instead of just using psychological theories that me as a researcher thought was important, actually going from the ground up and starting from scratch and asking people, well, what is important to you when you make decisions? We had some presentations by psychologists giving some examples, but then asked them to really think what was relevant, what was engaging, what do you think would be most important to include when we design the decision aids. So the underlying psychological theory that underpinned these was something that was very much informed by this PPI work. And we had an artist listening and creating this mural during the workshop, which is a nice way to share the information along with all the words that went into the scientific paper that was published. And on the next page, I can show you, we've just published this paper. Hamilton was the one who published the scale, but we've actually used this scale called PEERS. So it's patient engagement and research scale. So it gives a way that it's already been validated by other researchers to ask people, what was it like for you taking part in research? How easy was it? How convenient was it? Were there anything that could have been better? Did you feel listened to and part of the team? So we use that, and it's something that we can use as numbers, quantifying the experience and then reporting on it. And then it can allow us to be included if there's any bigger papers that say, okay, of everyone who's used PPI in research and has used this scale, what did they find? And then it becomes more powerful when we add together the experiences from around the world of different studies. And we also added on the opportunity for people to just write in their own words, share a personal narrative, a story, so we could hear anything that wasn't captured by the survey questions. So the key lessons, as I was saying, this was a big research grant, and we did have the funding, which I think was very important to include from the beginning. So something for researchers to consider at the very beginning of getting their idea for the project, because it takes time to build the trust, have that communication process. It doesn't happen easily where people just turn up and they've never met the people to really be able to share open and honest and honestly and feel their, you know, that their voice is important. They might come and not say anything, and that's not what we want. You know, we want to be able to hear from everyone. So really trying to encourage others to do that. And here's some of the quotes that were included from people in the paper that you can read if you get a chance. Um, you know, they had different things to say, and they're all important because they all experienced it differently. I think overall it was quite positive. They had some recommendations for what could be done better, and there's things that I would do differently in the next project because we learn as we go along and we learn from each other. Um, and the next slide is a paper that was just published by Nicola and Georgina, who represent Semicolon Charity in Germany, doing incredible patient advocacy work. And they're also part of ERN Genturis network. So this is really sharing from their first-hand perspectives living with Lynch syndrome, as well as all of their interactions with people in their charities, patient groups, social networks, and they've given lots of presentations internationally as well about their work. So encourage you to read that if you get the chance in the International Journal of Cancer. To the next slide, hopefully you already believed it or I've already convinced you, but people like Mev doing research, me in clinical and research, and Georgina as a patient advocate with Lynch syndrome, forming those partnerships and actually from the very beginning, listening to people and thinking, what are the research priorities? What are the clinical priorities? What are the gaps and what's missing? In the paper, they described this, you know, lack of information, decision support, care that's not joined up, it's not integrated, and how it can feel very fragmented, and that people are left on their own to go out and just Google or go on social media and find people to support them. And I'm, you know, as a clinician in the NHS, I know how much the resources are stretched and that we often feel we're not able to provide as many appointments or as much time for people as we would like. And so the third sector, the charities, patient support groups, and local peer groups actually fill so much of that gap, and often they're really not funded enough to do that, and they're doing it all in their own time. So it's really important to partner with, you know, the people who are the experts in Lynch syndrome really are the people who have Lynch syndrome and are living with it and their families. And so it's really, really important that we partner with them um, to include them along the way before we just design something and say, okay, does this work for you? It might not. And then we have to go back and change it. And that's not a good use of limited resources. So we're sharing and learning, generating new knowledge together along the way. It's with people, not for them. And it's really trying to challenge that power imbalance that, you know, like I said, I'm not the expert necessarily in a lot of these things. I'm learning from you. And co-design is really a foundational principle of PREDI-LYNCH, which is admirable. They're aiming for relevance, acceptability, and impact, and that's been thought about from the start. On the next page, we see, you know, I mentioned there's research that was involved in this, so there's some direct quotes from interviews that I did in the process of co-designing Lynch choices, and these really highlighted these gaps. Not enough good information that's not up to date, healthcare professionals that don't know about Lynch syndrome, haven't got enough education about genomics, having to go out and access care in different parts of the healthcare system in the community, and having other people who are not actually trained or supported, like family members or peers, to actually support them when they're not getting that from healthcare professionals. So there's an awful lot that was missing, and it was starting to try and fill the gaps, but there's still a lot more to do. And on the next page, we see some more evidence from a survey evaluation that's not yet been published, but hopefully soon, of once we'd, you know, got Lynch choices in as, you know, good of a state as it could be ready for implementation, we then rolled out a survey to say, actually, was there anything we're missing? Just checking how useful is it? How easy is it to understand? Would you recommend it to others? Which is quite important because often people are thinking about members of their own family or close peers who have Lynch syndrome when they're asked that question. So overall, the responses were very positive, and it gave us encouragement that we're ready to just roll it out. So we made Lynch Choices available, announced it at the Lynch Syndrome UK Patient Conference and in partnership with Lynch Syndrome Ireland and many of our other collaborators. So this demonstrated that there is feasibility, acceptability in a real world setting, and now we need to do further studies to test that in clinical practice of people making decisions in real time. So on the next page, you can see some of the next steps of, you can see from Google Analytics, there was over 7,000 users of Lynch Choices already. There's another decision aid that was developed by my team at Southampton called Breast Cancer Choices that helps with the decision about testing for breast cancer related genes. There's some more work planned to adapt that for men with breast cancer, other groups working with special charities. But for any of these things, cultural adaptation projects or adapting these kind of decision aids and information resources for other genes, it's really about embedding PPI from the beginning, conception of the idea, and all the way through the research life cycle, and co-designing the resources together, and then generating some real world evidence. We need to show that it's useful and that there's impact, and asking about patient reported, so directly asking people about their experiences, outcomes, such as we ask about things like cancer worry and distress, and satisfaction, to find out, what was it really like and what needs to be improved. And then it's an iterative process to go back and try to make things better together, and really adapting and evaluating the model in different healthcare systems and strengthening the international collaborations, because together we can do a lot more. So PREDI-LYNCH provides a model for that. It can be adapted. It's going to be, taking place in many different countries internationally. So thinking about how we can learn from each other and improving the care for individuals with Lynch syndrome going forward. So I wanted to thank I can't mention everyone in this amount of time. It would take the whole hour, but there's been so many amazing colleagues and charities and PPI involved. So I want to thank everyone. And also I showed you a few pictures just teasing that there's a wonderful meeting called EHTG. On the next page, I can show you that our meeting is now going to be held in Stockholm this year at the end of the summer, and it's just going live. That people can think about registering, and we have since the meeting 2 or 3 years ago, we introduced patient and public involvement, and since then it's not been negotiable whether that's included. It's expected that we need to make sure we have space in the program for our patient and public involvement representatives. So hope some of you can join us, and I'll pass over in case there's any questions. Thanks, Mav.